I just want to give a brief introduction to Lino's background so you know a little bit more about him. He was a 1990 graduate of New York Chiropractic College, now Northeast College of Health Sciences. And after graduation, with graduated close to undaunted, he returned to Canada and went into a post-grad studies program in sports injuries and spinal rehabilitation, leading up to his membership as a fellow in the Canadian College of Chiropractic Sports Sciences. Was that through CMCC?
Yeah,
Lino?
that was through the CMCC program.
Great. He then became an instructor in both the sports and spinal rehab programs at CMCC. And he served as a sports chiropractor and a consultant to several Ottawa. He's up in Ottawa, Canada. Both intercollegiate and provincial sport teams. He's also served as an independent chiropractic associate. I guess you would be a independent chiropractic provider for the Ontario Workplace Safety and Safety Program, as well as a rehabilitation and disability evaluator for the Ontario designated
Assessment centers. Yeah.
Yeah. What kind of centers are they?
It was
assessment centers.
It was an assessment center. Yeah.
So you were actually doing disability and rehabilitation assessments for injured workers.
Yeah, for a period of time in the 90s and early 2000s.
Great. For 34 years, he's been in practice and currently serves as an advanced practice provider in the Rapid Access Center Low Back Pain Program in Ontario, Canada, up in Ottawa. So with all that said, Lino, we look forward to hearing about the program.
Well, thank you very much, John. Very nice introduction. Yes, as John said, I am a graduate from NYCC and came back. I was originally from Ottawa and came back to practice in Ottawa. Had an opportunity to take the UPIT program for PSP, so I will I'll put my name in that and let you guys know that was kind of a great way to get ready for the what I'm going to be presenting today, which is the Ontario Rapid Assessment Program for managing low back pain. We'll talk a little bit about how they're integrating chiropractors back into our publicly funded programs here in Ontario, and how it's the PSP program has been a great interface for me to be able to do that. Please feel free to ask questions as we go along. The slides are meant to be just a guideline for us. I really want to give you guys an opportunity to ask questions about how the program works here in Ottawa. So are my slides up there now?
Not yet.
No.
Not yet. I thought we had done that. Sorry about this, folks. Let's do this one more time.
Sharing should work.
Yeah, we had just done it and getting back on there now.
Ah, there we go. Perfect.
I appreciate you guys being patient with me.
Yeah, it's okay.
Okay, so what we'll start with is giving you a little bit of an idea of where the RAC program really fits in. It's the Rapid Assessment Program is a program that kind of evolved from 2010 to 2017. It's a strategy that started to reintegrate chiropractors and physiotherapists into primary care capacity in our publicly funded system. We had been delisted in the late 90s, early 2000s from publicly funded care, and this was kind of the workflow model that reintroduced us back into some publicly funded care, at least for chiropractors in Ontario. So what you're seeing here is an infographic of how we take patients from primary care providers, and on the left side of that graphic, how they would get to see a surgeon for low back conditions. The RAC program, originally called the Isaac program, reintroduced chiropractors into an assessment role for some of these patients, and it really gave us an opportunity to be a first touch for some of these patients, many of whom didn't have any extended health care for chiropractic, and it was a great way to reintroduce us in there. There's, as you'll see, kind of a workflow where the entry into the rapid assessment clinic then gives you an opportunity to work through and see physiotherapists or chiropractors that are working at the hospital level. So from primary care, the next step would be at the hospital level. And at that level, the flow would then be to any services that may be surgical or additional imaging. And that's kind of what the original premise was for adopting this system. Spine care pathways are not new. This is right off of some of the PSP training that I'd done at UPitt. And those best practice pathways all have to have certain things in common. That being a system that everybody is familiar with in terms of classifying patients, a coordinated system of care that everybody is going to be consistent with, a record-keeping system that will facilitate communication and continuity of care. In ours, there's the EMR is portal that everybody drops their information in, and where referrals are made. And then processes and outcomes that are going to end up being evaluated to make sure that we're actually delivering on what we believe we're delivering on with our spine care pathway. Point of entry is very important, where the patient actually enters into the system and how they get there. Ours is based on a physician referral into the system. And then in order for it to be sustainable, we have to know how to allocate the resources so that there isn't waste in the system. And we'll see how the RAC system does that as we go along.
If I can interrupt you 1 second, I
Certainly.
got to give credit back to the Canadians for that definition that you just listed. We took that from an article by Forney, written Hamilton Hall and Daryl Forney back in 2011, up in Canada, about the Saskatchewan program. So kudos to the Canadians.
Well, we definitely go back and forth across this border, that's for sure. Okay. So one of the things that they did is they piloted the system, the rapid assessment system, again known as the Isaac system when it first came out. We piloted that over a period of about 3 years, from 2014 to 2017. In a couple of different regions to see whether we actually could see some cost savings, whether the outcomes that we were trying to track would be actually outcomes that we could reach, and whether streamlining the system would help in providing the referral sources, the patients to surgeons, decrease their wait time and give them the kind of patients that would actually be surgical patients. And certainly the pilot program found that even in the designated pilot sites that were provided, there was a significant savings just if we looked at reduced imaging, MRIs and X-rays. being done at a significantly reduced rate when you integrated the chiropractors and physiotherapists in an advanced practice placement position. Certainly the patients were happy with chiropractors and physiotherapists doing assessments for them and making recommendations and management for care. Some of the physicians' scoring was also improved as the physicians integrated more with chiropractors and physiotherapists. Their confidence improved in managing low back pain. And that was an interesting outcome to track. And by far, one of the most important factors was in being able to provide patients deemed surgical to the surgeons. So whereas in the referrals that were being made directly from primary care to the surgeons, about 50% were considered non-surgical. About 96% of those that were coming from the Rapid Access Center, the ISAC program, were deemed surgical. So it really helped to reduce the times that surgeons would have lost in doing assessments on patients that were not surgical patients. They hadn't exhausted their conservative care. This kind of is another workflow that kind of tells you where the primary care providers fit, the advanced practice providers fit, and that's between primary care and the hospital practice lead. So in our system, what we have is we've got chiropractors and physiotherapists working at 2 levels in a shared care model. The first would be actually in the community where they receive referrals from primary care providers and do the initial assessments of those patients, oftentimes emphasizing conservative care strategies. We also, at this time in our assessments, would highlight those patients that should already be moved to the hospital-based system where the practice leads can then facilitate the referrals to the surgeons or specialty clinics. So you have 2 levels where the physiotherapists and chiropractors can serve in triaging patients and making recommendations to management. Often, now I would serve at this level in the community, and then after there are practice leads affiliated with each spine center in the hospitals that would then accept the referrals that I would make there. One of the things in implementing the system and moving from the pilot program to our permanently funded program now is that we can expand some of the outcomes that we can look at, not only in reducing the costs for unnecessary imaging, but also in redirecting some of the patients from physicians' offices, primary care centers, into our shared care model if they do not show any emergent signs that they need to go to emergency. It'll also help to keep patients that may have flare-ups, but the emergency room would not necessarily provide the services that we would be able to provide in more of a management strategy in the RAC program. Developing relationships with the primary care team and on an ongoing basis really helps to support some of the strategies that we could then offer that the physicians can do within their own clinics. So you'll see that we'll talk about a core toolkit that's been designed so that in the first 6 weeks to 8 weeks of complaints, patients can actually be managed by their primary care team even without referral to us. by some of the support tools that the program provides primary care teams. And then not only are we offering the improved referral for our specialists at hospitals, but it's reducing wait times to see these specialists, which is one of the things that is often looked at in publicly funded systems, is to see where we can integrate providers that will help to reduce wait times to see specialists. This is a little bit of the referral form that we would get on our electronic medical record system. So there's just some basic information. We try and select for those patients that are subacute, certainly. We try and have the physicians at their level rule out any red flags so that those patients would be immediately referred to emerge. Try to take some of those patients that may have some chronic pain and issues out of the system. It's not really intended to be a chronic pain management portal, although oftentimes what we will do is we'll work in conjunction with some of the specialty clinics in our hospitals for those chronic pain patients if in the referral we find out. So we try and make the referral definitely for our subacute patient population that has either low back or leg pain. We do want the physicians to have an opportunity to request the reason for the referral, whether they're looking at a clarification of diagnosis, whether they're considering imaging and they want to get a second opinion as to whether the imaging is necessary or not, what type of referral specialist might be appropriate in this particular case, and our program will end up selecting for those patients that may have inflammatory risk factors, chronic pain risk factors, and appropriately select for the next step of referral. So we go back to this slide to basically demarcate the difference between the two roles at the community level, but also the practice leads will serve as an interface for the hospital level. So they sit within the hospitals and they will end up facilitating the referral to the surgeons. So our referrals from the community then go to the practice lead, and then those practice leads will take a look and see which specialty clinic within the hospital that patient is best served by. And that may be the chronic pain clinic, that may be the surgical clinic, it may be additional imaging that needs to be done, but that would be the role of the practice leads to supervise all of the advanced practice clinicians' referrals. This is one of the toolkits that developed as a result of the RAC program, and that's the core back toolkit. This is one of the things that we oftentimes will share with the primary care team that's referring to the RAC. It gives them a very streamlined way to manage their low back patients in primary care, giving them some detailed but very streamlined clinically oriented exam, and also some strategies with managing the patient with back pain, whether that's a back pain that is flexion-based or an extension-based. It does, John, you had mentioned the Saskatchewan patterns. This really came out of that in assisting the physicians in being able to provide some very easy recommendations that they can make to their own patients as they're waiting for their RAC assessment to take place. Our rapid assessment clinic also has a website that is a patient education website. So in our assessments with patients, we will oftentimes give prescription for self-directed care, for exercises, and there are videos and prescriptive pads that we can refer the patient. We can, in our assessments, circle and refer the patients to. They can go right back while they're at home to the videos that have been selected. And then after those videos, we'll take them right through the exercises they can do themselves. Some of the patients that we have are in rural areas and may not necessarily have access to a physiotherapist in their area, but this gives them the opportunity to follow along a prescription of exercises that we would make for conservative care, and can be very beneficial in getting patients to start seeing the benefits of self-care and education. Any questions at this time?
I have a couple. If nobody else wants to chime in. I have two that I'd like to ask. The first one is, when you cited that you guys are getting like 96% of your referrals to a surgeon are surgically appropriate referrals, have you had any pushback from the surgeons that you're being too specific and not sensitive enough with your referrals?
I've been in the program for about a year. No, we're not getting that. So the way it typically works is for every 10 referrals that we get in the office, about 10%, 10 to 15% will end up being referred to the practice lead. So we're managing by far the majority of the referrals with conservative care in our community. Those referrals, those 10 to 15% that go to the practice lead, about half of those, about 7.5%, will end up going on to the surgeon.
Okay.
And then of those, the surgeon will, about five of those patients of the 7.5 will end up having surgery. So
Okay.
there's the surgeons are not giving us pushback in the manner in which the process is unfolds. In fact, they appreciate the fact that in their clinical rounds, the patients that they're seeing from the RACs are far more likely to require surgery. Now, in our program in Ontario, not all patients have to go through the RACs to see a surgeon. There's still in the workflow sheet the ability to go directly to a surgeon from a primary care provider. What we find, though, is that when you drive that pathway, the surgeons are seeing a far greater number of patients that are non-surgical patients. And so they really appreciate the patients going through the pathway.
Great. My second question, are the practice leads chiropractors, or are they physical medicine and rehab, or what
No,
specialty?
all of the practice leads will either be chiropractors or physiotherapists, advanced practice chiropractors or advanced practice physiotherapists. Yeah.
Okay. Yeah, that's really fantastic. Okay, good. I'll let you continue on. I'll ask you more questions later.
Sure.
We have a question from Austin. So he says, what was your adoption rate or curve for PCPs using RAC versus their usual/habitual care pathway? Aside from providing the tools, what else was done or tried to promote use by PCPs, and what was the best strategy with that?
So the program, the RAC program, is not intended to be an all-encompassing program. It's intended to be a portal for management. So that's a very good question, because the strategies that we have in place primarily is as an assessment tool to figure out which patients would be make the best candidates for referral to medical specialists. But then we also will do some patient education. There are follow-ups that we can do with our patients that come into the RAC. Initially, it's to educate the patient on the benefits of an active therapy program and to integrate that at a foundational level with patients, dispel the fear of doing exercise, try and educate the patient on compliance and tolerance, activity levels that would be appropriate for them. We oftentimes will make referrals to community-based physiotherapists and chiropractors if there are clinical signs that manual therapy, manipulation, acupuncture may be indicated, and that's one of the things that we'll oftentimes do in our management strategies. We may make referral back to the family physician with respect to having a look at the patient's current medication, oftentimes to see if we can reduce the medication, especially the patients that may be on opioids. So there's a whole list of recommendations that we can make, both back to the family physician for their delivery of care, but also for community-based resources like physiotherapists and chiropractors. I hope that answers that question.
Thank you.
Okay.
John, you had another question.
Sure.
Yeah, I may as well ask it right now. The criteria for entering a RAC, a rapid access center, seems to be temporal. Are there also clinical findings that, like a nerve retention sign or a motor deficit, that would prompt a referral, or is it strictly temporal?
It's not strictly temporal. The acute care management is left up to the primary care provider. Okay, the initial 2 weeks, the initial 4 weeks of a flare-up of lower back or leg pain, it's primarily designed for that patient that's slow to respond, though. You are right, John. And where the initial strategies for managing acute pain is not working with a patient. There aren't criteria that are required for the primary care doc to complete, though. So we don't ask the primary care doc to refer based on a straight leg raise, based on a diminished reflex, although those are all parts of the core toolkit. The referral essentially would be for the patient that's not responding, and from and where they may have questions on a clarification for diagnosis, where they may have questions on the need for imaging, where they may have questions on the need for a specialist to intervene.
Wonderful. Thank you, Lino.
We certainly do start with having the family docs give us and the nurse practitioners give us some preliminary information, and maybe what I can do is go over kind of how the journey would be for a patient through the RAC, and that will give you a little bit more idea of how we interface with the primary care doc. So these would be kind of the highlights that we would look at for a case. The patient would be classified either into back or leg dominant pain when they're initially sent to our office. There would be a patient intake procedure, intake forms that they would complete, and they would include some scoring, like the start back tools, but also some history on their complaint and what makes it better and worse. We may or may not have imaging on a patient that first gets referred to us. And then it would be our role to take all of that and to go through our clinical examination to see if we can identify what the patient's complaints are arising from, and determine whether a referral would need to be made to the next level, to the practice lead for possible surgery, or whether it's a non-surgical patient, and then there's recommendations that should go back into the community. Let's look at a patient here with their... So this is a pain diagram that was of one of our patients that was referred. The patient is complaining of lower back pain, midline pain, but also some complaints in both feet, numbness and tingling in both feet. That's what we would have on the pain diagram. I hate to jump back and forth, but I think the notes are in the other. Yes. So I'd have to come back to this one. So I'll give you a little bit of a history on this one, and then after, maybe we can ask questions about what some of you may be thinking. The patient was seen at the RAC for an initial assessment. The referral from the primary care confirmed that the patient had previous spine surgery in 2012, lumbar spine decompression at L5, and that was the result, a surgery for an emergent cauda equinus syndrome. The patient had experienced some urinary incontinence at the time and had a single level decompression done at L5. When we were taking the history, it took the patient a long time to recover, about 6 months to a year, and she complained of residual complaints that remained as persistent numbness and tingling in both feet. At the time now that she's referred to the RAC program, and that was not a RAC program, that was directly to the surgeon through Emerge. At the time that she presented to the RAC, her complaints were primarily back dominant pain. She walked in with a significant flexion antalgia. She was using walking poles and said that she uses them a lot more over the last year. Her start back score was not high. It was a 5. The imaging reports were not included at the time, but the patient did confirm that she had been already sent for an MRI. What would you guys be thinking at this point before going into your physical examination? Or is there anything else that you would want to know about the patient history?
Michael asks, how old is the patient? Patient number 1.
The patient is 77 years old. Shall I move right into some of the imaging? So certainly we're thinking that after a single level laminectomy, that there may be some issues with the segment above. Not unusual for that to happen. Definitely a a patient with a flexion antalgia such as that, maybe considering some progression into stenosis. So when we did the neurological testing, the gait analysis showed that the patient had weakness with toe walking on the left. Her deep tendon reflexes of both Achilles were diminished bilaterally, but patella was responsive. Her sensory was pretty patchy in terms of to light touch, but she was hypersensitive on the right lower leg and foot. Manual muscle testing demonstrated weakness of left ankle plantar flexion and some weakness in the hallux. So definitely some neurological signs, but what do we need to consider at this point with a patient with pre-existing surgery? Well, one would be any of the residual neuropathies that may have been from the result of adhesions that may have happened from the first surgery. Okay, so that was one of the things to consider, and what's new and what is old in this patient in terms of her neurological signs and symptoms. Orthopedic testing, she definitely had some limitations with extension. Her flexion and side bending, though, was actually very good with no repetitive end loading, did not reproduce pain associated with that. SLR slump was unremarkable. She did report some complaints with back pain and with referral into her thighs with more of a knockless test or a hyperextension. And as we explored some of the exercises that we may be sending her home with, we found that if she tried to attempt to do any bridging, there was no pain-free zone for her at all. She would immediately cramp up in the legs. So now what are you thinking?
Come on, you clinicians. Speak up in the chat.
Anybody? Well, certainly I'm looking at, in this particular patient, at what the imaging is going to give us with respect to possible stenosis. With her low back, with her pain being primarily low back and into the buttocks, and the fact that extension was reproducing a lot of her pain, she was getting relief with flexion, and that exploring some of the bridging exercises, she immediately cramped up. We know that we're going to give her some flexion-based exercises for core strengthening while we're looking at that imaging to come in. Does anybody else want to contribute to this one?
Yeah, I'll ask you, Lino, what medications was she on?
She was on very little medication. She was on over-the-counter. She was not on any anti-inflammatory. She was not on any gabapentin. She was just on over-the-counter medication. Her primary barrier was the weakness associated with her walking.
And on her own, had she tried any other therapies? Had they sent her through a course of physical therapy, or?
This patient was a little hesitant to be doing that, and this is one of the things about internal dialogue that patients may have that they don't necessarily express with you until you develop a relationship with them. And that was, the patient felt that her original lower back and leg pain was mismanaged when she was originally experiencing it back in 2012. Which led to the emergence of the urinary incontinence and the surgery that had to be done for cauda equina. And so she's hesitant to access physiotherapy and chiropractic at this time, and was looking for a surgeon, and was looking for whether she needed another surgical consultation.
And who ordered the MRI that she said?
This would have been the family doctor. He concurrent at the same time as sending her to the RAC, he had already sent her off for an MRI.
And did he ask for gadolinium with the MRI? Did he ask for the contrast?
He did not ask for contrast. So, in this particular case, this is the patient's MRI came back and confirmed that there was lumbar spinal stenosis at 3 levels, L2, L3, and L4, with a measure of anterior listhesis at L3 over L4. So not surprising that extension was contributing to this patient's pain, and that was the reason why the initial assessment with her, we limited how much extension she would be doing with respect to her exercises, emphasized a lot of flexion-based protocols in this case, and subsequently we did send her to the practice lead for a possible stabilization with a surgeon, or at least the consultation for one. So the whole process took about 6 weeks for us to go from initial assessment from the physician to the RAC, from the RAC to the practice lead, and from that to a surgeon with the imaging provided. This is not the typical thing that we would do for patients with back dominant pain, though. We would expect those patients to do very, very well with conservative care. But in this particular case, we felt that the instability that she had at the segment above her previous laminectomy, it was a factor that should be evaluated by the surgical team, by the practice lead and the surgical team. So that's an example of how a patient with back dominant pain may end up at the surgical team at the hospital. We've got time for one more case, or shall I open it up to questions?
Yeah, by all means, if people want to ask something, raise your hand or type a question into the chat if you would.
We do have a question from Jeff Scher. Would you consider stenosis boot camp a la Carlo Amendolia for this patient prior to surgery?
I certainly would be having that patient try doing Carlo's boot camp. In fact, there's one of the things that I would love to see integrated into our referrals is having specific clinics that deliver specific programs that are evidence-based, such as Carlo's program, where we could actually direct the patient to a specific clinic in the community. And I think that will certainly be an evolution, the next evolution to our RAC program.
Jeff, if you have a resource on that boot camp with a link, if you could pop that into the chat as well, that would be great.
Yeah, if you're okay on time, we normally end at 1, but with the provision that we can go to 1:15 if you're still able. I'd love to hear a second case.
Absolutely, absolutely.
Okay,
So let's take another case. So this would be case number 2. So this, again, the referrals are oftentimes made based on either back dominant pain or leg dominant pain. This would be the pain diagram of a patient that presented with a referral that was leg dominant pain. Interesting. I don't know necessarily whether, as chiropractors, we would consider this to be leg dominant. Certainly it extends beyond the gluteal fold, but it doesn't radiate beyond the knee. There's some radiation to the anterior thigh. There's certainly some the patient saying that it's primarily buttocks and not lower back in their pain diagram. So sometimes the patient's intake forms and the primary care provider's referral don't necessarily seem to jive as closely as we might think. So this particular patient, 63-year-old male, presented a long history of recurrent back pain, no red flags, no yellow flags. In consultation, the patient confirmed that the leg pain didn't extend all the way down into the calf, was intermittent, and would flare up from time to time. Certainly was worse with standing and walking, and better with sitting. That it was an insidious onset, but that the most recent onset happened after being bedridden for an extended period of time from having a virus and a throat infection. So he had been in bed for a good 4 to 6 weeks trying to recover from this, had been admitted to hospital for it, and subsequently was discharged. The patient was a retired mechanic, had reported that he'd gone out, that he had been referred for advanced imaging. We couldn't confirm whether it was a CT scan or an MRI at the time. His start back scores a little higher, 6 of 9, and the patient did seem to have kind of a mild to moderate issue associated with symptom magnification of his complaints. He didn't have a significant antalgia. Neurologically was pretty well intact. No issues associated with weakness, deep tendon reflexes, a light touch. Orthopedic testing was pretty well unremarkable, except for some very tight hamstrings when we were doing the SLR. No radiculopathy, but certainly some tightness. The patient's active ranges of motion were limited in both flexion and extension. There was certainly no preferred direction that the patient felt better in or worse in. The hip screening showed some marked limitation with hip mobility on the left side, and then some significant tenderness posterior buttocks piriformis on the right side with no significant SI compression testing. So while the patient was referred with a referral indicating leg dominant pain, this particular patient was not a nerve pain, no radiculopathy in this patient. Primarily mechanical back pain, secondary to some deconditioning, and some that terms that I use, more of a lower crossed syndrome with hip flexor on one side and piriformis on the other. certainly not a patient that would be referred for advanced diagnostic imaging in my estimation, had I seen the patient first, not one that I would refer to the practice lead, a patient that would be prescribed some stretching and strengthening exercises to address some of the muscular imbalance, and then one that we would refer to see a community-based physiotherapist or chiropractor to assist with some of the pain management. We did a follow-up with this patient approximately 6 to 8 weeks later with complete resolution of his complaint, a better understanding of where the complaint came from, and a patient who recognized the need for doing strengthening exercises as a result of an extended period of being in bed as a result of his viral infection.
That was fabulous, Lino.
So sometimes leg pain is not surgical. It can be managed conservatively, and sometimes back pain is surgical, and it can't be managed or fails to respond to conservative care. So one of the things that I wanted to present from my experience of being in the RAC over the course of this last year.
Yeah, wonderful. Lino, can I ask you, when a patient presents to the RAC, do you manage the case? How do you make that decision? I'm going to refer this one out to a community provider, or I'm going to keep it in-house and manage it myself. Just time?
The management strategy, we don't provide at the RAC any manual therapy, manipulation, mobilization, modalities. Our role is primarily to instruct the patient education, and self-directed exercise.
Okay.
So
Perfect.
our parameters are primarily parameters to activate the patient and to educate the patient. If we feel that that patient may benefit from physiotherapy or chiropractic in the community, then after we would request that patient to contact their family doctor to see if there's somebody in the community the family doctor works with. But as I believe it was Austin that had said it would be beneficial to have a list of providers within the referral team of our region that we knew provided programs such as the boot camp program that Carlo, especially for our stenotic patients.
Thanks.
I have a quick question. The so-called lack of hands-on that you just mentioned, do you find that patients get frustrated with that? Is it something that you have to talk through with them? Obviously, there's the active care emphasis, which I'm sure is a huge component there. Do they get frustrated? How do you deal with that? What's your perception on that front?
I certainly, in stepping into this role, recognize that to a degree we are being handcuffed, because the strategies that I would like to deliver may be strategies that go beyond simply patient education and the instruction and self-directed exercises. However, when we talk about a sustainability, having a program be sustainable, I think our role has to be explained to the patient when they first come in. Certainly, we encourage the continuity of care from a community-based physiotherapist or chiropractor to work with their primary care team. And we can facilitate the recommendations that we make in our reports to those providers. We can certainly do that. But I like being I like the system as it is, where I'm not necessarily delivering the hands-on care, but offering an assessment and a recommendation to the provider who may be doing that.
How do you guys engage the PCPs? Do you have an educational program for them? Is there an administrative center with the RAC that goes out and how do you make sure you're using that they're using similar language to what you might use and they're not
So
catastrophizing?
the PCPs all have to be onboarded.
Okay.
The referrals that they make is through an electronic medical records with the office within the hospital where the practice lead sits. And then that gets farmed out. All of those referrals get farmed out to the community-based advanced practice providers.
Okay.
So the central agency would be sitting at the hospital with the practice lead, and they would onboard all of the primary care team referral sources. And then it's a short video training so that they can recognize which patients within their patient population would be best served by referral to the RAC.
Great. Gee, Lino, I can't think, are there any other questions? Let's see, Don made a comment here. Oh, yeah, he said your program really hammers home the idea that we need designated professionals who have the detailed training to take care of the majority of patients with spine-related disorders. And yeah, there's a broad definition of take care of.
I think
go ahead.
I certainly in the capacity in which I still maintain a private practice on a part-time basis. I still see patients. I still do hands-on. However, I recognize the value of putting chiropractors and physiotherapists in an assessment role in the management of lower back pain and sciatica to provide the support family physicians, primary care teams need, because that may not necessarily be their area of expertise. And if we can get, if the earlier we can become involved in the management of these patients' care, oftentimes I think we're going to reduce the chronicity and all of the other comorbidities that come with that. And so that really is my reason for stepping into this role at this late date in my career.
Yeah. Yeah, thank you, Lino. I on behalf of all of us here, we want to thank you for your time and your expertise and for sharing this incredibly innovative program up in Canada and how different professions can work together.
Absolutely.
And unless there are any last minute questions, thank you again for your time, Lino. We really appreciated this.
Great job, Lino. Thanks.
Thank you very much for having me, guys. All right. Yeah. Enjoy and happy holidays to you.
Happy holidays to you too. And to everybody who's on the call, thank you very much for joining us today.